We've looked at this scientifically in a number of different ways. In some of the efficacy oncology trials, the phase 3 trials, have had a cardiology sub-study to monitor things. There are other examples where we've started with cardioprotection up front. The problem with many of these trials is, first of all, they're small. Secondly, people with pre-existing heart disease or on drugs like ACE inhibitors and beta blockers already are excluded because those are the interventions being seen. And so you refine it down to a low risk population, so the absolute incidence of the problem is relatively low compared to real world populations, and then to look for a benefit, it can be challenging. So there is data that ACE inhibitors and beta blockers can potentially protect people from anthracyclines, but it's not one size fits all. So you have to personalize it to the individual, what their risk is, what their background cardiovascular problems, have they had arrhythmias, have they had high blood pressure, what are their current medications. For example, amlodipine is a very common blood pressure drug, but it makes a weak heart weaker and has no cardioprotection. So you'd want that patient, if they're going to have R-CHOP or ABVD chemotherapy, to actually be on an ACE inhibitor. Why use amlodipine to manage their high blood pressure? And so forth. So what we do is do an assessment and then personalize it to the patient. And some people just need closer monitoring, and if it's all fine, no interventions required. But you are right, we also need more trials. And I think there may be trials of systems of care rather than specific pharmacological interventions.